So I know I've got the post-lunch slot, so I've got to try and energise you all. It's just one that doesn't work very well. So we're going to quickly run through, Matthias and I, what have been the key questions that we've been trying to address in our work package, which is evidence synthesis and predictive modelling of randomised controlled trial data and real-world evidence. I'm quickly going to run you through some of the latest thinking on the methodologies and what we've learned about some best practices and recommendations. That was the pre-read that we sent you. Probably you didn't go through it all, but it was a key part of our work that we did. And Matthias is going to run through a couple of case study illustrations to try and present some of the issues that we've been trying to grapple with. And again, there's no one solution that fits all. We've been trying to, through our case studies, look at different components. We have developed some software and tools that we hope may be, again, applicable. We'll summarise what we're going to be generating for evidence synthesis and predictive modelling that we hope will be important and useful. And then we've got some questions at the end that we could take either now or through the discussion after this afternoon. So if you think of some of the questions that have already come up today, we've got these areas. Obviously, how efficacious and safe is a new medicine when it comes to market? We're looking at efficacy and safety. We're looking at patients in clinical trials, and often that's done through phase 2 and phase 3 randomised controlled trials. And evidence synthesis is, again, our typical sort of meta-analysis of those harmonised programmes under study conditions. But we want to know, well, how efficacious and safe is our new product compared to other therapies? So we're looking at relative efficacy, relative safety. Again, we're looking at patients in clinical trials. And again, this is where you're getting the indirect comparisons, the network meta-analysis techniques coming through. But again, they're based on study conditions, which might not be the question of interest. And then we want to ask, well, how efficacious will the product be in patients who are likely to receive it? So that's the third question. So we're looking at the relative effectiveness in the predicted patients likely to receive the product. So what's going to happen post-launch? What can we predict about the patients and who's going to get the product? And this is where we may start to use our individual patient-level data to use the covariates that we know about in patients in clinical trials, use meta-regression to try and, again, increase the precision of some of our analyses. But again, it's predicting from our study conditions. And the fourth one is, well, how effective and safe is this drug going to be compared to our comparators in those who are likely going to receive it in the healthcare systems where patients are being treated? So this is our real-world kind of scenario. So we're looking at what patients are going to get the product in the real-world setting. Can we predict that? We're looking at a much larger source of data, our controlled trials, clinical databases, clinical practice registries. This is the data sources that we now are looking at using. And we're getting into much more mathematical modelling to help us predict that those kind of settings under the real-world conditions. So bear those questions in mind as we go through this part of the session today. For the latest thinking on methods, we started off by performing very sort of thorough systematic reviews in the areas of network meta-analysis, indirect comparisons, however you want to phrase them. With increased data transparency, there is now more access to individual patient-level data, and that is, again, much more granular level data you can use in evidence synthesis. But what are the methods around that? And then mathematical models to help predict effectiveness. What are they? What do you have to do that? And we were aiming to really describe the state-of-the-art methods in these areas to summarise what are the key challenges, the different approaches that you can use, and to give, again, there are limitations, there are challenges, and to provide some best practices and recommendations. And those are the 3 papers that you had for pre-read. So again, if you didn't have time to look at them before today, I would recommend you read them after this meeting. So in terms of what is some of the recommendations that came out, so when you look at network meta-analysis, Again, we went through and presented all the different approaches that you can use, all the advantages of different ways. There's not a single way that you can do this. What are some of the alternative methods that you can use? We discussed in depth the methods that you can apply, but there are key assumptions underneath these methods, so we've tried to explain those as best we can. There are a number of technical details in these reports. There's different topics that you can cover, things like the meta-regression, accounting for different trial designs, measures for design-adjusted network meta-analyses, how you handle multiple outcomes, repeated measures. So these have all been summarised in these sort of literature reviews. And also we try to summarise what software is available to do this, because again, the analyst needs a set of tools to do this well, and what are some of those tools? So we think it's quite comprehensive. It's a valuable series of papers that can help you understand in a logical way and put yourself through a journey of what's evolved over time, what's the latest thinking. In NMA, there are a number of assumptions. I did want to just sort of, again, put a slide up to summarise some of these. Indirect comparisons still remain controversial. Not everyone buys into them. They have been around in Europe for quite some time, and they should be used with much care and attention. Anyone could combine data together, but is that the right thing to do? It depends on the situation you have. Ideally, we want to look at transitivity, the assumption of exchangeability as well. You know, can we compare the treatments? If we had all treatments together available at the same time, would patients be equally randomizable to any of those treatments that exist? If we have a series of studies, are they similar studies, the congruence assumption? So we need the studies to be similar in some aspects, and if you start to deviate from that, then that's part of the limitations of these methods. And where you do have head-to-head studies, which is what we do try to strive to have head-to-head data, but not against every comparator perhaps of interest. How consistent is the direct and any indirect evidence? And again, there are methods to look into that. But so these are some key assumptions that go along with these methods, and they do need to be thoroughly explored. So in terms of individual patient level data, great that we have more access to patient level data, but it does bring more complexity. And again, what we've done is describe again the advantages of having that increased source to level of data, but what are some, again, the limitations of those approaches as well. And again, there's lots of other things you can do when you have individual patient level data. So really looking at that heterogeneity in the treatment effect, what are some of the different types of outcomes, that level of granularity you have when you have patient level data, the more exploratory analysis of the covariates of interest, what range of covariates we have and how they've been collected. So we've gone through, again, a series of reviews of these techniques. And again, when you have individual patient level data, there is more complexity to the analysis that you're going to do. So what software do you have to do that as well? So when you do get patient level data, it's a much more comprehensive analysis, and that has advantages and disadvantages. So, our recommendation is you should always do a full systematic review with any evidence synthesis project you're going to do. And again, don't use individual patient level data in the absence of sort of poorly designed trials. So this is not going to give you a solution because of other poor design decisions you've made previously. When you're doing an individual patient level data analysis, we would still recommend that you do an aggregate level analysis, look at the summary level data as well. Again, you're building a story with the data that you have. And because it can take a long time to get access to IPD data, you have to build that into your strategy. It's not always easy to get. You may have issues with the data you do collect, and it might be difficult to summarise that data or integrate that data together. And then mathematical models, what models do exist to try and predict? And you might think there's quite a few out there, but we didn't really find that many. So again, we could identify key four approaches that are used and in a number of sort of key articles. So you can see some of those methods displayed here. And again, people do try to predict outcomes over time in different ways, and sometimes it's very well validated and sometimes it's not. And of course, with mathematical modelling, you need to have a very good way of not only developing the model, but then validating that model and not using the same data source, for example, to validate that model. Methods for predicting effectiveness, or at least in the real world, are conclusions where it's not done very much at the moment. We see that's going to be the area of growth. And we do want, again, to promote best practices of how to do this well. So part of this team is to lay out the different challenges that you'll have and how best to overcome some of those challenges. So that's really a summary of the literature review. Again, the papers are there. Please have a look. Part of our effort is to promote best practice in network meta-analysis and evidence synthesis and predictive modelling. We do want there to be more consistency in what people do, the assumptions that people make, how they've approached the analyses. I mean, I'm a statistician by trade, so I might be biased, but I do like to, think about my analysis. What's the question we talked about this morning that we're going to answer? Plan my analyses, understand the data that I've got, and not just wait for the data to arrive and then go and look at the go and do the analysis without that thinking. So now I'll hand over to Matthias. He'll go through some case studies. That seems to work okay.
Thanks very much, Chrissy. So one of the really exciting aspects of the GetReal project was that we could actually get individual patient data from real trials, and we could also get data from clinical databases, registries, etc., and really experiment with these databases and data sources and try out some of these approaches that Chrissy was talking about. And specifically, we've been working on 3 case studies, one on depression, one on schizophrenia, and one on RA, rheumatoid arthritis. And I'm just going to focus on the latter 2 for the interest of time, but we have done these 3 case studies and looked at different aspects of bridging the efficacy-effectiveness gap. So the first one is schizophrenia, and as I said, we really wanted to assess existing methodology and develop new methods for combining evidence on relative effectiveness and see how we can integrate data from RCTs with observational data. And we had, in this case, 168 RCTs, imagine, 168 RCT data, but on study level, aggregate level. And we had a very large cohort study, the SOHO cohort of 11,000 patients, where we had patient-level data available. SOHO is actually a collaboration of 5 different cohorts of schizophrenia patients. So we then created one of these beautiful network meta-analyses, and this is the network that you see with all the drugs. So, for example, this is haloperidol, and there are all the other drugs that psychiatrists use in schizophrenia, and many of these trials were placebo-controlled. Now, for some of these drugs, we also had real-world evidence from that collaboration of cohort studies, and they are now shown in blue here. In general, throughout the case studies, red is RCTs and blue is observational. Now, this is a hypothetical example of networks of RCTs and networks of observational studies. And look at the connecting lines between these nodes, and we'll just look at the comparison between 3 and 4. So in RCTs, you can have a direct randomized comparison, or look at the lines, you can have an indirect randomized comparison through drug 2 up there. And the same thing applies for observational evidence. You can have direct non-randomized evidence, and you can have indirect non-randomized evidence, again here through another drug, in this case drug 1. So we use these data to look at how the evidence differs according to whether it's direct randomized, indirect randomized, direct observational, or indirect observational, using this large database. And in this case here, this is drug 4 versus 15, you see that we have agreement between direct randomized and direct observational, but some disagreement, although confidence intervals overlap, with indirect randomized. In this case here, 4 versus 6, we see that we have agreement between the two randomized comparisons, the indirect and the direct, but disagreement with the direct observational comparison. So, how can we deal with this situation? How can we get over these discrepancies? And how can we examine what the factors are that really underlie these discrepancies? And I'm going to talk briefly about 2 out of 3 methods, namely design-adjusted analysis and, very briefly as well, informative priors from in a Bayesian framework, using basically the real-world evidence as a prior in your Bayesian model. I'm not going to talk about the 3-level hierarchical model. I think I'm not the right person. It's a very complex approach, and it is, however, very related to what I'm going to show you. So let's look at evidence from RCTs and evidence from observational studies, again, red and blue. And of course, with the observational studies, we have the issue of a high risk of bias and large precision, which may be spuriously large, too large. So what we can do is we can introduce in our model a term beta, which would correct for the bias in the observational data. And then we could, with a term W, we can play with the weight that we want to give to the observational data. We can say we don't want to give that much weight, we want to give much less weight. We can reduce the weight by dividing the variance of the observational estimates by that factor W, the precision correction. So we have a bias correction and a precision correction. And then we can combine the 2 sources of evidence. So we need to do this really separately for each study. That's very important to understand. And we add, as I said, the beta to the summary effect to correct for bias, and then we decrease the weight it carries in the summary effect by using the W term. If we have W equal 1, then we're taking the real-world evidence in full, if you like, at face value. If we set it to 0, we basically ignore it completely. And of course, it's difficult to get the correct values for beta and W. We need to talk to experts. We need to do sensitivity analyses, etc. And in general, I see this approach really in the spirit of sensitivity analysis. And let me now show you the example of what we see for 4 versus 6, just to illustrate the approach. So what you see is if we set W to 0, I'm not sure whether you can see it. Okay. In this case, we really only look at the RCT evidence. And now we can change the value of W and allow more and more observational evidence. So as we go down from this estimate to here, where the full amount of observational evidence is included, we add more and more observational evidence. And what you see in this case, 4 versus 6, is that it doesn't really make that much of a difference whether we include a lot or very little observational or no observational evidence. And interestingly, in this case, this was observed not only for 4 versus 6, but for actually all the comparisons. The observational evidence didn't really make that much difference. And in this case, you could argue you should include it in order to gain precision. The other approach that I quickly want to talk about is you can use a Bayesian framework and view the observational studies as prior knowledge, which, when combined with the observed data, gives you a posterior summary effect, as shown in the model on the bottom part of the slide. And you can then adjust for bias and downweight the prior distribution in a similar way that as I just illustrated, to address concerns of bias and over-precisions. And for the statisticians among you, dividing the variance of the prior distribution by that weighting factor raises the likelihood function to power alpha. But that's a real technical detail. So the key points here in this case studies are summarized on this slide. So you definitely want to look at the non-randomized evidence in a critical way. You want to look at sources of bias. And the best way of doing that is really having individual patient data from the observational studies. So you can use methods like inverse probability weighting within marginal structural models, for example, propensity scoring, etc., to look at what the biases likely are and how they affect the effect estimates. You really need, of course, as Chrissy already said, you need to pay a lot of attention to these different sources of heterogeneity, and you need to assess whether combining the data actually is a good idea. And as I said, or as I illustrated, there are several approaches that can be used to jointly synthesize randomized and non-randomized evidence. Whatever method you use, the quality, the sources of bias need to be assessed, and as I already said, sensitivity analysis is really what this is all about. So let's move to the second case study, which is the RA case study. And again, we had several, in this case, individual patient data trials, which we obtained from our FPI partners, which, as I said, is really great. And we also got access to 2 clinical registries, the Swiss RA registry and the UK RA registry. So we had IPD data, individual patient level data, both randomized and observational. And what this case study was looking at is really bridging the efficacy effectiveness gap. I mean, what often people fear is that the observed RCT outcomes in red, which indicate a large benefit in this case, conventional DMARDs and biologic treatment in this example, that this effect is actually substantially larger than what you will get in the real world, okay? And this case study really looks at this issue in greater detail. So the situation that we imagined was we set up a mathematical model that allows us to predict the real-world effect of a new biologic treatment which is not yet on the market in patients with RA, if only RCT data on the new treatment are available. So we're really trying to simulate a situation which is in line with the drug development process. So you only have RCT data on the new treatment, no observational data on the new treatment because it hasn't been launched yet, but you have observational data on an existing similar treatment, for example, the same treatment class. Okay? So a bit similar to what Lucien Abenheim showed this morning, we were thinking about graphical models, and we used directed acyclic graphs, DAGs, to visualize the different conditions. So the upper graph shows the situation that you have in RCT conditions, where basically you have covariates which influence the outcome, but because this is a randomized trial, they don't influence treatment. And you have efficacy modifiers which modify the treatment effect on the outcome. This is the RCT situation. And this one here is the more complicated real-world situation where you have covariates B that influence whether the treatment is available. The treatment, again, the treatment efficacy is, as in the RCT, modified by efficacy modifiers. But then you also have confounders, variables that are associated with the probability of getting treatment and also associated with the probability of the outcome. And this is, in this case, often this chap here, the doctor, who decides who gets treated with what drug. And this is also called confounding by indication and channeling bias, etc. Then you also have non-confounding covariates that influence the outcome. Now, where do we get the data from to populate, if you like, this model that I showed you on the previous graph? So just briefly, these are the outcomes, and in our case study, we really used the DAS 28, which was available both in the RCTs and in the observational data. Then the efficacy modifiers, they of course have to come from RCT data. And these are variables that in discussions with rheumatologists we identified as effect modifiers or efficacy modifiers. And they are also empirically, they actually behave, when you analyze these data, they do behave as efficacy modifiers. Then the real-world evidence data, covariate B, of course, is the calendar year because that determines when a drug becomes available. The covariates V, which are prognostic factors but not confounders, are listed here, and the confounders are listed here. And again, these variables were identified in discussion with expert clinicians and partly also based on data analyses. So we developed a mathematical model informed by observational evidence on who gets treated in order to simulate the real world, and based on RCT data on the efficacy of the treatment and of all effect modifiers and prognostic factors. Then, in the first step, we predicted the real-world evidence for RCT populations. And what I mean by that is we basically asked the question, what would happen with the same type of patients as the ones included in RCTs if they were treated in the real world? So if they were subjected to the type of treatment decisions that doctors make in the real world. And then we took this one step further and asked the question, what would happen if these treatment decisions were made in populations that are not included in RCTs, the real-world populations? Okay? And I've got only a few slides left. So this is what we find when we compare the effectiveness and efficacy in RCT populations. So the dark red basically shows you what we observe in the RCTs. Beautiful, strong effect, new biologic treatments, definitely better than conventional DMARDs. Now, when we subject this to what we see in the clinical databases, what doctors actually decide, who gets what treatment, then we see that the effect is attenuated. And the reason is that the doctors are, in our database, reluctant to give the new treatment, and relatively few, even of the RCT population, actually receive that treatment. And of course, this is very time dependent. I mean, this will change over time, but that can all be modeled. Then, predicted versus observed in the real world population. So these are real world populations, and real world decisions are modeled in this example. And what you see here is that the effect is less, but there is also a clearly a more pronounced treatment effect with the new biologic treatments. If you compare this with this picture here, however, it is clear that the predicted effectiveness is higher than the predicted effectiveness in the RCT population shown here is higher than the one on the next slide on the real-world population. The whole thing is moving up. So brilliant, isn't it? It's great. We can predict what's happening in the real world using mathematical modeling. Now I have to add a slight caveat here, namely, if you look at the observed, real-world evidence, then the model doesn't really fit very well, and we need to do some more work to find out what's going on here. Particularly, we have a problem with the effect of the conventional DMARDs, where we think there is some indication that the model is not appropriately parameterized. They're possibly unconsidered effect modifiers, prognostic factors, etc. So this is work in progress. But you get the message. So what we want to do is we want to deliver by the end of this year a Bayesian inference framework to connect information from various sources, namely RCTs and real-world evidence, individual participant data, aggregate data, to predict real-world treatment effects, to assess the efficacy effectiveness gap. And as I've illustrated, the main concern really is predictive, or if you like, internal predictive and external validity of these models. Particularly the external validity is difficult to assess, and the predictive also needs additional data that you may not have, but we're working on it, and we're quite excited about this work. Thank you.
So just quickly, a little bit on the software. So we have developed ADIS, which is the Aggregate Data Information System. There was a version of ADIS available at the start of GetReal, so we're sort of creating the next version of ADIS. And it has three key components. It's the ability to bring in summary level data, so you can actually download data from clinicaltrials.gov, which is, again, a good way of getting access to data quickly. You don't have to manually enter it in. There are state-of-the-art tools to do an NMA, and with graphics, it's a step-by-step process. So people who are new to this, we're sort of developing techniques to help to illustrate how to do this well. And again, there is some decision analysis techniques in there as well from the previous version. It's all built in R code, R software, that's freely available. So, you know, in industry, R is used. It might not be the main source of code, but a lot of people do use R now. So all the tools are freely accessible. A copy of an example of the interface. You do bring your data into the analysis. You'll get a network diagram. There's different options you can choose in terms of which kind of methodology you'd like to use. And you'll get some results out as well. So why ADIS? Well, it makes the software more accessible to a broader audience, promoting the best practices of how to do a really good analysis well, try to prevent coding errors that can exist through sort of automating some of the code, and again, making sure that you can bring your data in and eliminate that data extraction, which can also take some time. So we have followed existing other good guidances. So NICE have developed a number of technical documents. We follow those good practices as well. So the ADIS does allow us to model some of the case study work we've done in GetReal, but doesn't have everything built in. So we can't do the predictive modelling in ADIS. But again, the code that we are using will be made available through our publications. So what we will give to stakeholders at the end of this year is, again, our methodological guidance, best practice recommendations for how to integrate both summary level and patient level data, and also how to predict models and predict effectiveness. There are software tools. So if you don't have anything in-house, you could consider using ADIS or if you have your own tools. We are developing a series of education and training materials. We do understand that with some stakeholders, this is still quite a new area of research. So we're taking people on a journey. But, access to now real-world data evidence is there, and there are methods now to combine that data. And if people want to do that, we want them to do it well and be informed about how to do this. We've done a number of publications, a number of outreach to conferences, so ITSPOR, DIA, some of the biostats conferences in Europe. So this has been rolled out in the last year or so. And again, through discussions with yourselves today, we do have a methods workshop on September the 15th. So if you really want to know more about the methods, want to challenge us, do a deep dive, do come to us in London on the 15th of September. That's going to be our deep dive of the methodology. How can you help? Well, these are some of the questions that we've come up with. What do you think about these methods for combining the different data sources? Do you have any really major concerns, and how should these be overcome or considered? Will these methods be useful for any projects that you need to do looking at relative effectiveness? How would you use these methods? Will these methods and results be acceptable to address some of the questions that you have? We've talked about a range of questions that you may have as different stakeholders. So again, there's no one solution fits all here, but we're hoping that these methods could be a tool to answer some of the questions that you have. Are there any key issues that we have not either considered or addressed? I know today is just an overview, but please look at some of our materials and see whether there are any major concerns. And we are interested in the software, so would you use ADIS? Would that be a solution for you? Would you need any additional support? So these are the kind of things that we're seeking feedback from. With that, we are finished for sure.